When I was asked to join you, and I appreciate the opportunity of coming here to Tucson to do so, I was asked to talk about Obamacare and its meaning to all of us. Now, its meaning to all of us depends really on who us is. Now, I realize, and I'm going to be speaking on Saturday, actually, up in Rico, that many of you here have certain disabilities, or you're interested in people with disabilities. The Affordable Care Act has a great deal to do for those of us in the disability realm because of the way in which the law was written, and particularly with regard to some of the stipulations that we'll get into during the presentation. But if us is everybody, and I'm going to be emphasizing that in the presentation, it really does have an impact for all of us. It is a very important, major piece of legislation, and I'd like to go on. I think I'll be there, okay. What we're going to talk about today is really just 3 or 4 basic questions. Why are we here with a reform piece of legislation of the type that the Affordable Care Act is? What are the problems with the health system, and what are the things that brought us to it? One of the things I like to emphasize is, how do we get here? What is it about the history of this country that brought us to the point where we are now in a new era? A new system of care is going to be generated and provided after the passage of a piece of legislation that both parties have been crying for since 1972, when Nixon proposed modifications of the Medicare and Medicaid Act that was passed just 6 years prior to that. Yet nothing had been done for nearly 40 years, I guess, 70 to 010, yeah, 40 years. And yet we have a major piece of legislation that was passed. So the question of how did we get there, I think, is something that is always interesting. The history, if you know the history of a phenomenon, you know something about the phenomenon that most other people don't know. And I hope we can get to some of those discussions. One of the things that I find most interesting when I talk about the Affordable Care Act, or about anything having to do with health care, is that most of us have no idea how the system works. And when I say most of us, I would include my colleagues in the medical profession, who probably are more ignorant about how the health system works than most of us, who are not physicians, simply because they're dealing with it from their narrow perspective. You know, the doctor who sees gynecological problems thinks everybody in the world has a uterus and a problem with that uterus. Now, we know that's not true, but he doesn't, or she doesn't. And the same is true with other members of the specialties as they go through as they become members of the specialties. Because what you focus on, you know the old story, when you're a carpenter and you're working and your tool is a hammer, every problem becomes a nail. Those of us in this profession see the nails that we create and which we deal with every day. And so a short discussion of how the system works is sometimes very educational and hopefully will give us insight into what this piece of legislation can do for all of us as we move forward. And of course, the most important question, I think, which we all want to ask, is where in the world are we going now that we have this legislation on the table, but it really hasn't got started yet. It's like the cars at Indy are revving up, but the guy with the white flags, you know, hasn't said, he said start your engines, but he hasn't said, okay guys, let's go. And that's really the big question, is where are we going once the first of next year goes thing. Now, the question really has to be, does the Affordable Care Act respond to the problems in the system? Does it respond to the ways in which we have historically solved problems? And does it respond to the future needs that we're going to have as we move forward? Does it improve the system? Is it, in fact, the bridge to the future? I like to call this the iron triangle of medicine and medical care, because This is, when I go through this, this is really how we got to where we were 2 or 3 years ago when Obama, 4 years ago now, when Obama took office. We were in a situation where 50 million people were without insurance. Many of them had just lost their jobs in the last year and a half, or in the last year, 09, 08 to 09. And they had, as a result of losing their employment, had lost their insurance. And so they were bereft. They may have had all kinds of problems. They did not have access to a physician unless they paid for it out of their own resources, and that could be very expensive. 50 million people, 16% of the population, is not a rational way of providing a civilized nation with services that they need. The other problem that clearly got us to where we are is the incredible escalation in costs that have been taking place, of which I'm sure you're all familiar. When I was first studying these problems back in 1970, 68, 69, 70, it was easy to remember because in 1970, $70 billion was spent on health care, and that was 7% of the gross national product. That would mean the gross national product was around $1 trillion or $2 trillion. 7%. Today, we're spending $2.7 trillion. That's a multiple of, do the math, let's see, 70 billion to 2 trillion. That's about several orders of magnitude higher than it was before. How did we get that escalation over the last 40 years? Nothing else has gone up. Even General Motors cars haven't gone up at that rate. But health costs have. And that's a question that needs to be addressed. It is now bumping up against 18% of the gross domestic product. And you hear people saying, if we don't solve this problem and get health care costs under control, then the whole country would be doing nothing but spending money for health care, and we won't be able to do anything else. Now, there's some truth in that. If you take the chart and just plot the curve that I described a moment ago, it'll go right through the roof because it is accelerating faster than the economy is growing. But it doesn't have to be that way, and it certainly, I think, with the Affordable Care Act, won't be that way, and we'll talk about the reasons why. But the worst part of the problem that forced us to come to this Reform Act, and I put the doctor in the middle because to some extent the doctor used to be in charge of the whole thing, but unfortunately today that's no longer the case. But our quality, the thing that we need, we as people, we as citizens, we're not as interested in the cost unless we have to pay for a service. What we want to make sure is that we're getting the care that we need, that we deserve, that is appropriate, neither more than necessary or less than necessary. Quality is a measure of, do the persons who get it achieve the objectives that they want? Are they improved? Are they made healthier? We're ranked 37th in the world amongst our competitors. Western Europe is all over us, is much better healthcare services than we have. Japan certainly does, Taiwan does, New Zealand, Australia, and so on. So clearly there's a problem with what we like to think and used to think and always argued that we had the best medical care system in the world. That's no longer the case, and we hope to get back to that status. Now, right now we have too much service being provided. There's 150,000 unnecessary deaths that did not need to occur. Deaths in people, had they had adequate care before they died, would have not died. That's an unconscionable data. Our infant mortality is high, especially in minorities. Life expectancy is below the rest of the world, or at least the developed world. And let me make a point here on this point, because most of the debate with regard to health care reform and this act, and you hear it today, the president's budget comes right out of it, is we're concerned about cost. Costs have to go down. Well, let me make a point. Bad health is a higher cost than a dollar value. If you don't have good health, if the society doesn't have good health, if your children don't have good health, That is an extraordinary cost that we all pay because an unhealthy individual is an unhappy individual. An unhappy individual is someone who can't produce and be productive and be supportive of his family and his friends and the people who love him and her and whom that individual loves. The cost of ill health is never measured in these statistics, but that is in fact the most important and most significant aspect of why our quality is down and the impact it has on all of us. And we'll talk a little bit more about that as we go through this discussion. But before we get discussion of the Patient Protection Act, let me just make a couple of points. There are a lot of statements that you have heard that have been made by a bunch of folks around the countryside that are just flat out not true. This is not a federal takeover of health. This is not socialized medicine. Socialized medicine is something I'm going to talk about in just a minute. But what the Affordable Care Act is not socialized medicine. It is not rationing of health care. It's not a death panel bill. It doesn't reduce Medicare services. I would hear this story that this is a job-killing bill. The Republicans in the House of Congress for the last two years in the last session passed for 33 times an act to withdraw, to repeal the Affordable Care Act. And often they would say it is a job-killing bill. If there's any piece of legislation that I'm aware of that creates jobs, that builds the economy, this is one at the highest level of that list because it is not a job killer, it is a job creator. And it will change the way in which medicine is based. A state Medicaid cost increase, there is some truth in that, but not to the degree that people would argue. As a matter of fact, the reason why our governor is supporting the expansion of Medicaid is because it is necessary for the economy of the state, and the money that we will get in Arizona, as contrasted to what we'll be spending, is far in excess of what the state would spend over what the federal government will give us. Clinical care will improve, it's not a degrader, and most importantly, when you hear this kind of discussion from those who would turn this legislation back or repeal this legislation, or argue as did, it's on another slide that not in this slide. Senator Johnson said that this bill is the greatest infraction or the imposition on our freedom of any piece of legislation that I've ever seen. A flat-out, unmitigated, terminologic inexactitude. It is not true. There is nothing about freedom, unless you believe that not being able to get health care is freedom. This bill will increase your ability to get health care. Okay, on to the next. How do we get here? Now I want to talk a little bit about the history because, again, as I said earlier, knowing how we get to a place is a way of knowing what the place is we're at and where we might be likely to go from here. Now, I mentioned a moment ago that this is not socialized medicine, but we did create a socialized medical program right at the beginning. John Adams signed in 1798, a piece of legislation called the Merchant Seaman Act. The Merchant Seaman's Act was passed because, from an economic perspective, this country's growth was dependent on moving goods from Boston to New Orleans, from Memphis to Charleston, and so on. We were a trading country. Our economic base was moving goods and services around by shipping, by and large. And it was a very difficult thing for a seaman, if he fell off a spar or was injured in New Orleans, to get back to Boston to see his primary care doctor. So the federal government said, in order to protect and preserve and enforce and to maintain our economy, we should have a medical service system at each one of the ports around this country, so that when seamen or other members of the government are traveling, and members of the military as well, they could go to these publicly funded, governmentally owned hospitals and be served by doctors and nurses who were paid by the government, who worked for the government, and who were in the employ of the government. Now, that is the definition of a socialized medical system. We created one by our founding fathers, actually, in 1797. And yet today, when you hear the term socialized medicine, people all run out of the room and start to cry, or they do whatever happens when they're terrified by some great monster that's hanging out in trees. We created a socialized medical system in 1778. Now, it's interesting to note that that system became the basis for the public health system, which Bill worked for how many years, Bill?
30.
30 years. And you didn't feel that you were just a big socialist, did you?
No.
Okay, so he wasn't a socialist, but he worked for the system. The public health system was created in 1797 in the Merchant-Siemens Act. It created probably the finest preventive medicine program and service delivery system in the world today. Our CDC, our Centers for Disease Control and Prevention, is looked upon from the whole world to keep us all healthy, not just Americans, but the Chinese and the Orientals and the Indians and everybody who has a disease problem of one kind or another. The Centers for Disease Control is called in to resolve the problem and tell us what's going on. That was John Adams' vision, or at least that's what came out of John Adams. Now, it's interesting to note that in 1982, the 19 public health service hospitals that were still serving the merchant seamen of this country were closed as an economy measure by President Ronald Reagan. So the concept of service for one group and the economy for another has been a dialogue that has been going on for over 250 years in this nation. Now, I like to raise this because in 1853, a woman by the name of Dorothea Dix, who I'm sure most of you have heard of, was able to get the Congress under President Fillmore to pass a legislation to provide a hospital in the District of Columbia for the indigent insane, as she called it in those days, for those people with mental illness, those people with mental disabilities, people who had the ability to make it in the normal world. She felt that if we built quality hospitals to serve their needs, we could return them healthy back into the community to be productive members of society. Something which all of us with disabilities of any kind understand fully. If the system allows you to return to the community, irrespective of your disability, to carry out your economic function, your loving function, your family function, your job function, then all of us are improved by that thing. And she had that vision. And President Fillmore had that vision. She was then able, after the election of 1854, when President Franklin Pierce was elected, she was actually able to get the Congress to pass an omnibus bill, which stipulated that the federal government would help and go with states to fund mental health hospitals, land granted and supported by the federal government and by state monies, to build these hospitals in every state. Can you imagine today what it would be like in this state if we had had 150 years of experience working with a health system for the mentally ill, where we would have logic and reason and universal support for providing care to that particular group of our society? But Franklin Pierce had a different view from Mr. Fillmore. President Pierce, in his veto message, made a very clear point that again runs through the fabric and the fiber of the American tradition. His veto message said, while I agree that this is a very important group that must be served, I am distressed to think that if Congress passes something to serve the population of insane indigents, what is to stop them next year for simply creating a bill to provide for the poor in general? Serving the needs of the poor was not something that Franklin Pierce felt was the responsibility of government. So these be our brother's keeper, and people have to be independent and take care of themselves, is a force, a conflict that runs throughout this system. And that's why I think it's worth going back and reading, and you can get it off the internet, reading President Pierce's veto message. It stipulates, it will teach you a lot about what's going on today in Washington, D.C. It hadn't changed much. But 50 years later, of course, we all remember that Teddy Roosevelt, who had passed the Food and Drug Administration Act in 1906 as a way of improving food and drugs, because people were obviously dying from badly manufactured products, also decided that he would take a page out of Bismarck's book, where Bismarck in the 1870s had created the national health system for Germany. Teddy Roosevelt said, we need a national health system for this country. And with the support of the American Medical Association at that time, he was nominated on the Bull Moose Party. He was supported by the practitioners in this country, and he went on to get actually 30% of the vote, or 20% of the vote, but it wasn't enough to carry the electoral college. And as we know, President Wilson was elected, and all we got from President Wilson was, cutting back on the number of hours that people worked, and you couldn't send your children to work in factories. He was the one who signed the child labor laws. But so the history of health care for this country is a long one. Now, in the 30s, we know that Theodore's cousin tried to get under Social Security a universal health care package. But Francis Perkins, his labor secretary, said, Mr. President, we will not be able to pass Social Security if you continue to keep health care on the ballot, because the American Medical Association today is completely against you, and they have control. They have been talking to every one of the congressmen who go to their practitioners, and that Congress will not pass them. So Roosevelt said, all right, we'll back off, we'll just take the Social Security, and we'll try to get the bill passed over the next 5 or 10 years. Well, it didn't get passed over the next 5 or 10 years, but something else happened during that period. Of course, Franklin Roosevelt died. Harry Truman became president. Harry Truman was a very liberal Democrat, as you all remember. At least those of us who are old enough to remember. I don't know how many of them here, but at least some of us do. And Harry did a very interesting thing when the war was over, and he saw all of these people coming back, many of them professionals, many doctors, many nurses, many medics, and so on. And there was pressure at that time to expand the hospital system in this country. So the Hill-Burton Act, one of the most significant pieces of legislation in this country with regard to recognizing the need for hospitals in communities if you're going to have a medical system, because without a hospital, doctors aren't going anywhere, certainly. Thousands of hospitals were built in communities all across this country from 1946 till 1975, I think, when the act was actually transferred over to the Public Health Service Act. And it stipulated that you had to have certain requirements in order to get into the Hill-Burton program. And it was a way in which communities built services for their population. Now, he tried something else 2 years later when he was elected for the first time as president. And he had run on the same position that Teddy Roosevelt ran on, that he would pass a national universal health system for this country if elected. And he introduced that bill, I think, within days of his inauguration in January of 49. And that bill failed. And it failed for two reasons. It failed because the medical society at the time was even tougher than it was in 1937. And as Harry Truman said, the AMA is a trust and a mean one. And I just want to let you know, as a matter of exposure, that I spent 25 years as a delegate to the United States, to the American Medical Association. And I know it's a mean trust, but it's a damn good trust. It is a trust that has done a lot of good things. We'll talk about that if you're interested, but it's not necessary here. But the point is, in 1948-49, the American Medical Association saw universal health care as socialism. We're going to go down the drain if we have this act. And Congress backed away from it. But they backed away from it for another reason, too. And that is important to understand, because that is one of the reasons why we have had such a difficult time in this country moving toward social reform, and particularly health reform. Does anybody want to hazard why it didn't pass? Here he had a Democratic Congress and a Democratic Senate, and he had just won as a Democrat. And he couldn't get a piece of legislation that would provide health care for everyone, north and south, east and west, in this country. What was it? Any guess?
Maybe threaten the practitioners?
Well, that's why the AMA fought it. But the Southern Democrats fought it for a very simple reason. They would have to provide care to a population they didn't want to in the hospitals. Even though they had separate but equal hospitals, like they had separate but equal schools, the notion that everyone would have the same coverage was anathema to that particular group of people who still maintain that kind of us versus them. So these are the forces that go on in the United States. And when the next approach took place, when Lyndon Johnson addressed that, he had already passed the Civil Rights Bill. He had already said, we are not going to have segregation or racism or discrimination in this country. We're going to adhere to the 13th Amendment. We're going to adhere to the 14th Amendment. We're going to live what the Supreme Court has said we must do. And Johnson passed that bill. And as he passed it, he said, you know, in signing the Civil Rights Bill, I have just given the South over to the Republican Party. And I guess that's what has happened. But a year later, the issue that occurred in 48 was no longer a problem. And with a very strong Democratic majority in both houses, he was able to move Medicare through the system. And he also found that he got attached to the Medicare bill, Medicaid. Medicaid is a different problem. Medicare is for us old geeks. If you're over 65 like me, you get Medicare. Well, you don't get a lot. You get all your hospital bill covered. Not all of us go to the hospitals. Maybe a third or 40% go to the hospital in any given period of time. But it allowed us to also buy in at 20% of the total cost, buy into doctor services. So we could all go to a doctor with a small copay. And then over the course of time, under Bush, we of course got the drug part of the bill, so we now have a certain amount of drugs paid for. Not out of the federal government, by the way. That comes out of the deficit, but that's another story. But the point was, two major pieces of legislation, Medicare and Medicaid. Medicaid serving the needs of the poor in conjunction with the same kind of concept that Dorothea Dix had, which was if you live in a state, the federal government will help you to get health care working in tandem with the state. Initially it was a sort of a 50-50 match. Today it's more like 60-40, and in some cases under the new legislation it'll be more than that. So that there was this collaboration and cooperation between the federal government and the state governments to serve the needs of those people that Franklin Pierce thought shouldn't be covered at all. The indigents, the poor, the disabled, the weak, the infirm, and so on. Now, we know the disaster that occurred when Bill and Hillary tried to pass something because they didn't have the support of either the pharmaceutical industry or the insurance industry. They thought they had the support of the Chamber of Commerce. It turned out they didn't, and the result was that their bill didn't even get a hearing in Congress. So, 15 years later, or 12 or whatever it was, can you see that? Does that come through? The color's not quite right. When Barack Obama was in, and he was able, with a majority in both the Senate and the House, with a great deal of work and the expenditure of a huge amount of political capital, he was able to pass the Affordable Care Act. That's the history behind it. And you can see that the tension, the conflict, the arguments on different sides of our cultural relationships is what has made that bill so complicated. It's not the bill that many of us would have wanted. Representative Lopes had a bill in the Congress in this state which far exceeded this in terms of giving everybody the services they want. A single-payer bill where the state would say, we are going to cover the needs of the people who need health care. And we'll do it by taking Medicare, put that in the pot, we'll take Medicaid, put that in the pot, we'll take the money that's being spent by the purchasing of insurance, which is 20% of most people's salaries, by the companies that provide insurance, we'll throw that in the pot. And if you put those $40 billion into the pot, everybody in Arizona can have health care. Is that a fair assessment, Phil?
It is.
I mean, you've got a great man sitting here who tried to do something for all of us that we worked to get, but we failed. It's a nice try. Good tries, though, don't always give this. But this was a great try. And it's not perfect, but it is quality, and it is good, and we'll talk about it. Okay, it changes the system. Let's go through all this. Am I spending too much time? I'm probably spending too much time. Is there a timeline here? Everybody bored yet? Okay, stick around. These are things, if I step out of the way, again, these are things which make a difference on our system. People were denied health care, and you all know it in this room, because of the fate that was given you for reasons that you had no control over. Franklin Roosevelt once said, the state has a responsibility to serve the needs of people who are poor or without work through no fault of their own. Is there anyone in this room who feels that they have their problems because they did it to themselves? I don't believe that. No fault of our own. Preconditions, when denied by an insurance company, is a way of saying, you're not a human being that we want to deal with. Wrong. This law changes that. Changed it for kids immediately. It's changing it for all of us in 2014, January 1st. Kids who didn't have health care could get it because under their parents' thing, the dollar limits on coverage, a great thing. If you go to the hospitals today, you can run up $100,000 in cost in a minute, or in a couple of minutes, maybe in a week. And if your insurance says, well, you pay the first $10,000, and then after $90,000, forget it, Jack, we don't pay anymore. That's a cap on the bill. No longer is that going to be possible. It did another thing, and we'll talk more about this in the future. Preventive services, there's a whole title in this bill on prevention services across the board, not just in the public health sector, not just in the field of preventive medicine, but in the field of primary care and secondary care, preventive services for home services, for long-term care. Prevention is something that saves money. Not in every case, but in a lot of cases. And it's something that is very important and is part of this bill. We had high-risk pools, and I'll talk about that, and I know about it. 85%. This is another way of saving money. The question was asked, are we going to be able to save money on this bill? Well, that's a question that isn't completely answerable, but one way you can save money on this bill is by obligating the insurance industry to spend at least 80% of the money they get from your premium and mine on health care. Wouldn't that be an innovation? Rather than spending 30% on marketing, 60% on something else, salaries for their CEOs. Now, Medicare operates with an overhead of only 5% or less. So to give the insurance industry another 4 times as much overhead to operate on is almost a gift. But they're still fighting about that, and they continue to fight about that. But hopefully, the HHS will be able to hold them to that 80 and 85%. 80 for small companies, 85% for the large corporations. The insurance exchange, that's going to be starting now. Our governor has chosen to let the federal government do it, which will mean that you will be able to look at, right on your computer, the kind of thing we can do with Medicare supplements. You know, an A plan, a B plan, a C plan, a D plan, and each one lists the services that are provided and so on. So you can make a rational choice of what you need. And you can do that right on your computer, punch a button, and you will be able to get the healthcare package that makes sense for you. Obviously, there will be an expansion of the number of people who can get the care. The 50 million that we saw a moment ago who do not have coverage will be diminished by about 20 million. That's not clear today because some states will not accept the Medicaid program, although I can guarantee it in 2 years they all will, because the cost of turning it down is huge. But if a state does not accept a Medicaid program for the poor up to 133% of the poverty line, then there still are going to be a lot of people who are poor but not poor enough to get into the program. I mean, the irony of Medicaid is that if you're very poor, you can get covered. But God forbid you should earn $1 more working, cleaning the toilets at the local restaurant down the street, make $1 more over that minimum, you're off the case. Your kids no longer have care, you no longer have health care. That's a rational system, forget it, not in my book. But anyway, so 20 to 30 million people will be covered under the expansion of Medicaid, up to 133%. That will be the kinds of things we did in this state. Men who don't have kids, adults without children, can be covered if their income is low. It'd be nice if we did that for the prisoners in this state, but unfortunately that's not covered well. We've all heard about the mandates. All of us are going to have a purchase one of the types of insurance from the exchange. And if we do not, then there'll be a fine. But I assume most people will want to have coverage. I don't understand why anybody. There is a group. I see them all the time. They're driving back and forth in Phoenix. People who drive around at 75 to 80 miles an hour on a motorcycle with their hair blowing in the breeze. So there are people who live in denial and say, no, it's going to be me. But when that guy without his helmet runs into an abutment, guess who pays for him? All of us. Somebody's going to have to make that decision at some point. All right, so the prices, the government will say to an insurance company if they try to raise their premiums next year for more than 10%, there'll be a discussion and a challenge. So insurance companies will probably make an effort to keep their, how do I make this thing go forward? Okay. Now, the fundamental benefit to all of us, whether we're in this room or we have chronic disease or disabilities or that we're just normal walk-around people, is this piece of legislation, this part of the bill, which is right up front, and which stipulates directly what every insurance plan must provide. It must provide ambulatory patient services. It must provide emergency services. It must provide hospitalization, newborn, care for the mental health and substance abuse. This is a big one. This bill, presumably or presumptively, will help the state of Arizona cover its seriously mentally ill section. How much is that? $2 billion, isn't it, Phil? Something like that. I mean, it's not small change. Because in this state, there is a law that was written in while we were a territory, that the counties are responsible for the poor, the indigent, the uninsured, those without families, etc., etc. Counties must pay for those services. That's why in 1984, 85, the state passed a law to incorporate under Medicaid, because Medicaid, of course, would pay for half of those costs. So the access program in the state was actually created to cover the costs that the counties by law must carry out. The behavioral health issues is one of those issues. We must provide for the seriously mentally ill. We don't do a very good job. But we go back to Dorothea Dix. Wouldn't it have been nice for a federal standard across this country that would help us, not just with the seriously mentally ill, but with those who aren't so seriously mentally ill, or those who might be problematic behavioral problems when they're in high school or in grade school, where we could pick them up and recognize them and serve them and work with their families, work with their primary providers, and get them the early materials or help or assistance that they need so that they don't end up on the supermarket parking lot shooting people ad nauseum in this city 2 years ago. Prescriptive drugs will be covered, an important one for those in this room. I'm not sure I know exactly what rehabilitative and habilitative services all means. I'm sure there are those in here who can describe that in much more greater term. But I do know that those services now cannot be denied anyone when they need it. And so one of the great moments in my medical education was going to watch at the Howard Rusk Institute in New York, watching a man walk into a room having lost his arms in the Second World War and walk over to a table, reach down and go, ah! And then throw it together, and then with this hook, latch the thing, tie it up, and then sit down at the table with this set of prostheses and drink a glass of water, something he had not been able to do for 30 years following the war. When I saw that, I said, that's what medicine is all about. And that's what this piece of legislation is all about. Because every one of us, at some point, has some form of disability or problem or chronic ill that we need to have the rehabilitative and the habilitative services that most insurance companies in the past would not cover, but certainly will cover today under this. Laboratory services, preventive services, this is an important one. We'll talk a little bit more about that as time goes on, pediatric services. Now, this is the system. How is this legislation going to change this system and make it so that all of us can achieve the kind of services, not that we want, not that we think we should have, but that as citizens of this country we have a right to have. A right to be healthy. And again, it goes back to the notion of the cost of illness. If we have that right to be healthy, then this system and this law should allow us to do that. Let us look for the moment at the total costs. These are costs to provide the care in each one of these elements. The public health system, which serves all of us. Good food, safe drinking water, gets the sewage away so that we don't have to think about it. The trash is taken up. These are all part of the public health service delivery system that we pay through taxes. It costs a pittance, $200 per head, to get all of those things done. Have you been to Africa lately? What do you do when you want to go get a public water system? You make sure you take your anti-diarrhea pills. Because public water systems, in terms of preventing disease, is probably one of the greatest developments of all time. And making sure that we get rid of the ordure that we put into the septic systems. Those are important public health things. And yet, for just 2% of the total cost, this society is pretty well protected. If we get an epidemic, the CDC guys, right, the CDC guys are right here, the Public Health Service. The big costs, wait, I didn't want to go that way, but that's all right. The big costs, obviously, are here in the middle. The ambulatory care system, which I have split between some secondary and primary care, ambulatory care is very simple. It's the care you get when you walk into your doctor's office. You're ambulatory. Now, sometimes when your primary care doctor sends you to a specialist, you walk into his office. But that's secondary care because you would not have gone to the orthopedist or to the urologist or to the neurosurgeon unless your primary physician felt that you needed it. That's the way it should work. It doesn't always work that way. But the point is, these are ambulatory cares. The hospital care cost is, however, where the big money is being spent in this country today. If you look up here, it says $800 billion. I think that's low because I don't think that number comes from a source that is being quite honest with regard to all the costs that are being paid. And I don't know how many of you saw the article that was published just last month in Time magazine and called The Bitter Pill. Who saw it? Just raise your arms. That's not enough. Go onto the website, and I think I can give you the website here on this presentation. It is a discussion of what goes on in the hospital sector to guarantee that the private non-profit hospitals in this country, we're going to talk a little bit about, what did I say, 40, I don't have to remember. There are almost 5,000. The fact that they're making almost 12% profit on the money that goes through them for medical care is unconscionable. And they don't pay any taxes. Profits in a nonprofit just get put in a box. They don't pay taxes. So we have a hospital system which is in essence, according to that article, and I can tell you it is true because I've been there and I know the costs that are being talked about. There is a way of the hospitals taking us all, and our insurance companies, to the cleaners, and that needs to be changed. And that's one of the things that this bill will do. Now, you got other costs on there, the pharmaceutical costs, and I can't argue, that's going to be high. $500 billion, this is the overhead. The overhead just to shuffle the paperwork between the bedside and the back room and the insurance company, and the insurance company back to the back room for things that have to be filled, and then back to the insurance company, or to the doctor's office, or maybe back from the doctor's office, and then the doctor's office has to send it back and forth. The pushing of paper in this country is outrageous. And every insurance company, all 1,250 of them, have a different set of forms. And if you come in to your doctor and you have insurance company A and your wife has insurance company B, they have to fill out 2 forms. That's logical? No way. The Affordable Care Act probably will change that. So that overhead is huge, and the total costs we know. Now, I want to talk a little bit about another facet of this system problem with regard to the people who are served. Most people in this country are healthy. About 60% healthy, and most of them are insured. Well, the purple is the uninsured. Those are people with insurance, like most of us here, who have reasonable good health. And then, of course, the 14% are the Medicare elderly, and they're a little bit more sick, but they're not as sick as, they're not chronically ill, most of us aren't. The 16% who are without insurance, and then the 14% who are insured, sometimes with that little white triangle, which is a Medicaid, that's the Medicaid coverage. Some of those people have chronic disease, but most of the people who are insured with chronic disease are insured, and they work for a company, or their wife is working for a company and they're covered, or whatever. So there's a large number of people with insurance, but who are also unhealthy. And it's interesting to note that today, about 40 million people, that little white wedge there covering the green and the purple, about 40 million are on Medicaid. And usually that's about 100% of poverty. The rest, if you're in the South, North, if you're in other parts of the country. But that 40 million is going to go to 50 million when Obamacare comes in place, because we're going to expand the numbers up to 133%. So we're actually going to increase that number of people on Medicaid, and that's one of the big arguments, oh, it's going to be too expensive. But here's another chart, and look at what the issue is with that chart. The green, who are over only 14% of the people, are using, what did I say, 60%? 60% of the resources. Now, let's think about that for a minute. Who are in that green population? A lot of people with cancer, a lot of people who have had a stroke, a lot of people with cardiovascular disease, a lot of people who have suffered trauma and disabilities for whatever reasons, neurological problems or whatever. Those are the four big ones. Now, some of those probably could have been resolved early if we had a more aggressive preventive medicine system which made it a requirement to vaccinate everybody, all kids be vaccinated, to make sure that all adults get their vaccines when appropriate, to make sure that when you're 50 years old, your doctor says, oh, Bill, I understand you're still smoking. When are you going to give that up? Have you tried a patch? Have you tried an e-cigarette? Have you tried something to get you off the destructive element of the cigarette and allow you to learn how to abate your nicotine addiction? If we did that with everybody who's a smoker, all 70 million of us, we might reduce the number of people in that green area. And the same applies to other aspects, mental health problems. If we could prevent these things early, if we could get and talk about having sure that mammograms are appropriate, that other forms of clinical examinations, which are now all covered under the Affordable Care Act, and which were not covered under most of the insurance plans, then we will begin to take a bite out of that big green section. And when we take a bite out of that big green section, we are going to be saving money. But more importantly, we're going to be improving health. You know, there was a study done many, many years ago with regard to Social Security. Excuse me. Social Security. They looked at the first 30 years of the Medicaid program. And there were three types of people who got to the Medicaid program. There were those who got to be 65 and they died before they were 75. That was about a third. Then there were those who got to be 65 and they lived until they were 85. And then there were those other folks who lived until they were 95. And it was all about a third of each of the groups. How do you explain that? The people who got there and died in the first 10 years were clearly bringing chronic disease into the window, into the age group, into the Medicaid program, Medicare program. If they could have been served better to reduce the probability of their having chronic disease when they got to be 65 by having a program when they were 55 or 45 or 35, then they might have been more like the folks who lived to 85. And the ones who were genetically really the lucky ones, you can't change those guys. They're going to live to be 95 anyway. But it's interesting to note, you know, while we've been sitting here for this last hour, we're all getting younger. We're all 10 minutes younger. Let me tell you why. When I was born in 1937, my life expectancy as a white male born in the East Coast was 65 years. That's why the Medicaid program, that's why the Social Security program, by the way, was established at 65. Because they figured, well, hell, half the people are going to be dead, so we don't want to have to pay for that more. So you might as well, you know, that was a logical way of establishing a number. Today, my grandchild, who was just born a month ago, has an expected life expectancy as a male of something like almost 80 years. So in the last 75 years, I've gained 15 years, or 60, or 70. Well, if you do the math, that means that every hour we're getting younger by 10 minutes. Now, why has that happened? It's happened for two reasons. One, because in the 1850s and 60s and 70s, people began to realize that you could actually do things in society that prevented disease. You could get better water. You could get better, so you could do, improve sewer systems. You could have in 1906 in this country, the Food and Drug Act, so that the medicines you take were at least not going to kill you, and that the food that you ate was not going to kill you. You know, more people died from bad meat in the Civil War than were killed by bullets. You know, those are the kinds of things that happened in the 19th century. In the 20th century, they didn't, because we had instituted a public health system to try to reduce the probability of disease amongst the young and middle-aged and so on. Now, that was very successful. Today, the infant mortality rate in this country, albeit high compared to our neighbors across the world, is 6 per 1,000 infants born. When I was a medical student, it was close to 50. Just in the last 30 years, we've improved medical services for women who are pregnant and reducing the probability of death. And we've improved the pediatric services for the kids when they're born. But something else happened 35 years ago that has helped all us old geeks. Passage of Medicare. The passage of Medicare means that those of us who passed into that window of Medicare eligibility now get the kind of coverage that if we couldn't afford in the past, and I used to see them and my wife used to see them when we were interns, people who came in having worked their whole life, now with a chronic illness, whether it be tuberculosis or cancer or whatever, unable to afford the cost of care and ultimately dying as a result of inadequate services. Now, those two events, the passage of Medicare on the one hand and the passage of public health regulations on the other, have done what I just said, we're all getting younger by 10 minutes every hour. Now, that could be greatly enhanced if we pass, and with the passage of the Affordable Care Act, by incorporating for that green group all of the things that are written into this law about preventive services. And it's a whole, I won't go through the whole litany, it's an incredible amount, but you will find today that when you go to your doctor's office, they will be offering you preventive services, which in the past were not covered under your health insurance. So let's go on. Wait, I just missed something. Okay. Oh, well, okay. Now, what are the costs going to do now that we have this new law that has been sanctioned by the Supreme Court? It certainly is not going to be voted out by the Congress in the next 2 years. It's going to take effect this coming January. By the time the next Congress comes into place, whether they're one side or the other, it doesn't matter, because we will all like the bill so much we're going to say, okay, just let it go. That's what happened with Medicare. By the time Nixon came in power, there was no way that they were going to throw it out, although there were still the same arguments. But at this point, on the primary care side, a huge development is taking place. This law stipulates that primary care is primary. It is something that the administration supports, argues for, will enhance, and is in favor of by paying off all of the loans of people who say they're going to go into primary care if they're nurses, if they're nurse practitioners, if they're physician assistants, if they're doctors. Wouldn't your sons and daughters like to have their medical school loans of $200,000 eliminated if they go into primary care? That's happening. And that's happening, and people will expand the numbers. Now, that means that there's a cost associated with that, but there's also a benefit. And that benefit is we're going to have more trained people in this country. Hopefully up to 50% of all doctors will be primary care providers. Today, they're less than 30%. Every other major country in the world is at the 40 to 50%, because that's where the action is. That's where you prevent disease. That's where you identify problems. That's where you treat early rather than often. All right, so that's going to happen, and we're going to find that the costs in the primary care area are going to go up, and you'll hear people say, we can't afford to have all of these new doctors. How are we going to find them all? We're going to find them because we got incentives to get them. And we're going to build a system that will expand our primary services. But here's where the big savings is going to come. Now, we talked about the Brill. I talked about the Brill argument, the Brill article, and you've got to get that. We've got nearly 5,000 of these hospitals in this country. About 4,000 of them are nonprofits. They don't pay something. We got nearly 800,000 beds. I think we actually have more than that if you look at some of the federal beds and other things. But 800,000 beds. That's about one for every 2,000 people, I think, or two beds for every 1,000 person, I think, if you do the math. Maybe 3 beds for every 1,000. 36 million admissions to hospitals. Now, what does that mean? That means a little more than 10% of the population goes to a hospital every year. Now, some of us, and our older folks and chronic disease people, go a lot more than that. And a lot of us don't ever go there. I mean, a lot of people never see a hospital until they're practically on death's door. But that's not a large number for a population of our size. And it's actually less than you see in Japan and other places. That constitutes about 200 million bed days, however. And the expenditures in the hospitals are on the order of 800 billion, that's with a B. That's 10 to the 9th. For those of you who understand that notation, I can only deal in that because billions and millions all of a sudden, as what's his name, Dirksen said, a million here and a million there, and pretty soon a billion here and a billion, and pretty soon you're talking real money. But this is real money. We're talking 18% of the total of the whole business. Now, if we can lower those costs, and I'll talk about it in this way, and I'll show you how we might do that. These costs should go down. If you have $800 billion, and the profits that are being generated from that $800 billion constitutes even 10%, that $90 billion is money that should be returned to the system. Those are nonprofit hospitals. Those are hospitals that pay no taxes. Those are hospitals that run bake sales every year and get all the warmth and the friendlies of the community to support them because they're our friends. They get 1% of their budget from the bake sales. The rest comes from Medicare and Medicaid, the profits, because their billing system is archaic. The Affordable Care Act gives the administration, if they take the responsibility, the ability to look at those costs and begin to bring them down. And let me show you some of the places where it can happen. These are just a half a dozen items that people can get in hospitals. The dollar value here on this side is what the average in this country is. The dollar value on the other side, the average in Europe. Now, the MRI machine in this country and in Europe is made in the same place by the same people and sold at the same cost. There's a difference. Why should we be paying for an appendix operation 3 times more than anywhere else in the world? Are our doctors that much better that they deserve that kind of increase? Now, that's not to say that we shouldn't be paying our professionals an appropriate wage. Hell, they spend 15 years after college, or is it 15 years or 10 or 12, whatever it is. Yeah, depending on the specialty, at essentially a reasonably low salary of only $50,000 a year, paid, by the way, from Medicare and Medicaid. And yet, when they go out and practice, some of these guys won't even take Medicare patients because they don't get reimbursed. I don't want to be pejorative with regard to my profession, because I do love my profession, and I love the doctors in it because they're taking care of me in pretty good style. And I have enjoyed the time I spent working with the AMA, in spite of the fact that sometimes when I come back from an AMA meeting, I want to chew a radiator. But that's only my personal view. C-sections, 3 times. Hip replacements, 3 times. Bypass surgery, 2 times. Is there any reason in the world that those disparities have to exist? No. There should, because if you look at the lowest cost in some of these places, there are places that are charging in this country less. So that obviously there's a way of getting the cost down. If anyone is interested in that particular point of view, there is an article that was written in the New Yorker in the June 4th issue of the New Yorker, 2010, by a man by the name of Atul Gawande, G-U-W-A-N-D-Y, Atul Gawande. He writes frequently medical stuff. He's a physician in Boston. He describes the difference in cost to the Medicare program in two different counties in Texas, which are only 200 miles apart. And yet the cost of the care provided to the Medicare patients in one county as compared to El Paso, the first one I can't remember, El Paso, just 200 miles away, is almost 2 to 1. And then he talks about another county in Colorado, for the same services, for the same populations, 65 and over, for the same type of services, it's 1/3 what it is in between. Now, something's wrong here, folks. That's the kind of thing that the Affordable Care Act now has the authority to begin to change. That's when you hear President Obama saying, I'm willing to cut money from the Medicare program in order to reduce the deficit, although it's not clear that the Medicare program at all has anything to do with the deficit. The Medicare program, by and large, is paid for by money that's put into the pot by us, the elders, and by those who are working under their feet in there. But, you know, if it makes the group in Congress come around, that's a good argument. But this is the way to do it. You save money on Medicare by saving the resources, cutting back on the fraud, reducing the amount of waste, building systems in the hospitals that prevent disease, don't encourage it. That's the way you save money. And that's what Obama's talking about. So when you see people arguing that Obama is trying to cut back on the Medicare dollars, he isn't really doing that. At least that's not how I view it. So this is maybe unable, but the administrative costs, that's another whole thing we have to talk about. Now, I put up this slide because I like wheels. I'm an engineer, you know. Engineers always deal with wheels, right? But where is the future for us? Where are we going? And I'm getting done. I'm almost done. I need another hour or so. We have the Merchant Seaman Act, which was the first attempt to serve the needs of a demanding population. Dorothea Dix tried, she failed, but had a nice shot at it. By the way, the St. Elizabeth Hospital that was built under that original plan is still operating, is still providing clinical care, is still one of the better hospitals in the community for psychiatric care. At least I think that's true. Yeah. My wife lived in D.C. for years, and it's part of the public health service, and it works. Medicare and Medicaid were clearly major advances. The Affordable Care Act is a gigantic step in the right direction. It can improve quality. It has already improved access for people who didn't have access. It certainly will reduce the costs if everything takes place as it should. And particularly for people with chronic illness, people with disabilities, people with problems that in the past they could not get insurance for, that act will make a big difference. That will be what we will find after Affordable 2014. But we might be able to go even further than that, because we don't know what's going to happen in the 2014 election. The Congress could be red, and if that's the case, we'll go back a couple of wheels. If Congress is blue, however, we have an opportunity at that time to rethink the problem of what it is and where we are trying to be. Are we simply going to be worrying about the cost of medical care? Are we simply going to be worrying about Obamacare, socialized medicine? Or are we going to be asking ourselves, how do we improve the health status of our community? How do we reduce the problems that separate us from those other countries that have a different system and where their kids live longer and when they're born they don't die as fast and so on? If we begin to ask that question about what is the kind of society that John Adams wanted to have, the kind of society that Franklin Delano Roosevelt tried to get, and which Harry Truman got in part and failed, and which Lyndon Johnson said, this is what I think we can have. And Barack Obama had the courage You knew what I was going to say, right? Had the courage to stand up and say, I'm willing to expend political capital to get this done because if not now, when? As Bobby Kennedy said, if not us, who? If not now, when? And Obama took the courage to do it. We could go the next step. We could develop in this country without much cost, and probably less in the way of the regulations that you were talking about at the very beginning. We could move from a diverse system of Medicare and Medicaid and private insurance into a system which still uses the private insurance companies. There's nothing wrong with it. Germany has been using private insurance companies for almost 175 years. Switzerland has a good program using private insurance companies. In France, they use private insurance companies. Scandinavia is all socialized medicine. England is a mixed bag. There's a national health system, but there's also a private sector. You can go to the private doctor on Harley Street if you wish. And in Canada, to some extent, you can do the same. There's a public system which covers about 90%, 95%. But if you want a private doctor to get your hip done or your whatever you want to have done, you can do it. Even though the Canadian system would provide it to you, and probably at lower cost and certainly equal quality or better. But we could go that way and develop a Medicare for all system, which would mean that all of us, every man, woman, and child, whether you're an immigrant or a child of an immigrant or an elder who just came from Africa or whatever, regardless of your precondition, regardless of your race, your religion, your economic status, we would all have access to care at essentially no or limited cost. That's what the Medicare program provided to those of us in our age group. Now, we don't get long-term care out of that. If I have to go to a nursing home when I become crazier than I am, my wife's going to have to take care of me in a nursing home. But maybe we could get that covered as well. Because if you do it right, with the right kind of controls, and the right kind of objectives that stipulate these are the kinds of, as was stated in this law, these are the kinds of things that must exist in a nursing home or in a hospital. And you must have preventive services and you must have quality people. Then we could have a system akin to Canada or these other places, better than those places. See what they do. I turned something on. Oh, geez, this is good. Okay, so that's where our steel-belted radio may be in the future. And we may even have something new from that. There's now wheels that don't even use air inside. Have you seen those? They actually are all rubber and they bounce, and so they're very kind of nice. Where am I? Okay, problems still remain. We all know what these cost problems are. Whoops. And, the uninsured will, under Obamacare, the uninsured will still be there, but only at less. Costs may continue to rise, I think not. The insurance community still has a lot of power. That's a major problem. We need to find a way to use that 80 to 85% and the 10% rule to make sure that the insurance company plays the game in the way the game is now written to be played. Because they don't always want to do that. I mean, this is capitalism, and capitalism that's the way it is, and there's nothing wrong with it. We've built a great company as a result. Country. Hospitals are beginning to gain power. That's a little disturbing because they too are looking at their bottom line and not at your bottom line. And that's not the right way to deal with medicine. There used to be hospitals in this country as I traveled around. You go in, if you come to this hospital, patients in this hospital need to pay no services. Sisters of Charity or whatever, the Lutheran Church. There were hospitals where they did make their budget by the bake sales because there was no Medicare and Medicaid. That's not true anymore. And hospitals today are businesses which are looking for market share, looking for profits on the services they provide, and so on and so forth. Filling beds that pay, not beds for people who don't have insurance. ACA can promote quality, ACA can certainly hold down costs if it's done right. Medicaid expansion, increased access to care is a problem. We can talk about that in question period. And this is an important thing. The Affordable Care Act does give patients the opportunity to make appropriate choices for the care that they think they may need through the exchanges, and to choose the kinds of programs that they know will cover their needs. This is not true today. Your company makes a decision as to what they can afford for health care, and then you find out later that it didn't cover what you needed, or that the pills that are on their formulary aren't the ones that you need, or that the doctors that you've been going to for years don't work for the particular group that insurance company works with. That's not true under the Affordable Care Act. Okay. Providers also, if they take the responsibility that is being given to them, will also be able to control their destiny. That's a question that is, if you want to read the State of Arizona Medical Society publishes every month a book, a magazine called AZ Medicine. By the way, Phil, did you get it? Do you get it at all?
I don't get it.
Try to find a copy for this month,
Question.
for the spring edition, because there are several articles on the Affordable Care Act. One of them is fairly good. It tells you essentially how to do it. But then there are several others that give you many sides of the problem. And it's interesting to read that in light of knowledge, because there's a lot of non-knowledge that's being promulgated in that textbook, in that text. But it's worth knowing, because this is how the medical community thinks and feels. They feel they're being squeezed out of the game because the hospitals are taking over, and yet they have the authority under this act to gain control if they so choose. Whether they will is not a whole question. So in conclusion, the history of this country tells you something about where we are. The systems persist with cost, quality, and access, but hopefully it will improve. Affordable Care Act deals with these problems in a direct way. It improves the services for everyone. It provides access to care expanded. Costs will, but I think costs will go down, and they've been coming down. But the future is, Casey Stengel said a great thing one year when somebody asked him how the Yankees are going to do this year. And he said, making predictions is really hard, especially about the future. I have a hard time making predictions about the future because this country is so confusing sometimes. This may be a long way away, what I just described on Medicare for All. It may be a long way away. On the other hand, if the right decisions are made in Washington and the insurance industry really does their job and plays by the rules, many of them will probably get out of the game because there's not a lot of profit to play by the rules. And if that's the case, we might find we are going in a totally different direction. So I thank you for the opportunity to speak with you today, and if there are questions, I'm very happy to continue.